Welcome to the Princeton Spine Joint Center podcast. I've just had a great conversation with Zach Perlman. He is one of the co-directors for our Department of Regenerative Medicine. We had a great conversation about what regenerative medicine is, how it could be helpful in musculoskeletal care, PRP injections, and some of the expectations and some of the risks and benefits of PRP injections, and some of kind of the pitfalls and the drawbacks of regenerative medicine in general. If you've ever been told that you may benefit from a PRP injection or regenerative medicine, or you just have any interest in kind of newer technology or newer advances in medicine to try to treat a lot of musculoskeletal issues, I think you'll really like this episode of the podcast. If you don't, feel free to skip this episode, but look for future episodes. Welcome to the Princeton Spine Joint Center podcast. I'm here today with Zach Perlman, who is one of our co-directors for the Regenerative Medicine program here at Princeton Spine Joint Center. Zach did his fellowship training with the San Antonio Spurs down in Texas. Like myself, he is a sports medicine physician, and today we're going to be talking about the field of regenerative medicine and PRP injections, and what that might offer some of our patients who are suffering from musculoskeletal issues. So, Zach, what exactly is regenerative medicine?
So in the broad sense of terms, regenerative medicine is delivering a product or a cell into a diseased tissue or organ, in hope that it will regenerate and heal the damaged tissue.
So is that different from like a corticosteroid injection or a cortisone injection?
Yeah, so they work differently. Corticosteroid injections have been around for quite some time and are great treatment for acute injuries, muscles, joint injuries, osteoarthritis, and some sprains and strains as well. PRP is a newer technology and a treatment for musculoskeletal pain that has been developing over the years since the 1950s or so.
From the 50s?
Yes.
Wow.
Yeah.
So it's really been around for a while. How come it's just becoming a little bit more popular now? I
think that in about the 1990s was when it first came into sports medicine, when Alan Mishra from the Bay Area in California, he treated a quarterback's Achilles injury, and he came back and ended up playing successfally after that Achilles injury, and that was Steve Bono.
Oh, okay.
Yeah, and since then it's been very popular, for professional sports teams.
Yeah.
And the first I've heard of PRP, which is a subdivision of regenerative medicine, was when Kobe Bryant.
I was going to say Kobe was the one that really kind of brought it to the mainstream, at least from me. You hear that he went to Europe. Well, he's going to Italy for this new type of injection. But yeah, that's really where most people have heard that from. So I was actually surprised that it's been out there for so long, but I think it's really kind of been more prevalent in the past 10, 15 years, I would say.
Yeah.
How exactly does it work, as opposed to a cortisone injection?
Okay. So, if, for instance, men, when you're shaving your face, if you start bleeding, the platelets are very important for that, to stop the bleeding and to help regenerate the tissue so that, it has a platelet plug, a fibrin plug, so that you're not bleeding out. Okay. Same thing with women if they're shaving their legs. So there are multiple growth factors inside of the platelet, and these granules in the platelets. So once they're activated, they release all these growth factors and the site will heal. The problem about a lot of musculoskeletal problems is the platelets can't get there, or they can't get there in the right quantity. So when we're doing a PRP, we draw the venous blood like you're at LabCorp or Quest, giving blood for your doctor to test. And then we have a centrifuge machine, which spins for 5 minutes at like 15,000 RPMs, pretty fast.
Yeah, I would say so.
Yeah. And then you actually see in the centrifuge that there's there's like a yellow kind of apple juice color, and that's the plasma, which is the liquid component of your blood that has a lot of proteins that are dissolved in, and then there's a small layer of platelets at the bottom of that.
Okay.
And then you'll see the red blood cells in below that in red.
Okay.
So the red blood cells, deliver oxygen to our body. So we actually discard the red blood cells. We discard the white blood cells in the majority of cases.
Okay.
And what's concentrated is the platelets.
Okay.
So a normal human has between like 150,000 to 350,000 platelets per microliter.
Okay.
So when we do PRP, it's about 10 times as much.
Okay.
So we're really concentrating the platelets.
How much blood do you need to take for, I guess it depends on injections or the person. How do you know how much blood to take?
Yeah, so that's a topic of debate because this science has been advancing over the last 10, 15, 20 years. We're working out a lot of the kinks.
Okay.
And depending on the injury, like you said, for osteoarthritis of the knee, for instance, we draw about 15 to 20 milliliters of blood. Okay. And then in the end, we're left with 5 milliliters of platelets. Okay. But if it's a different injury, if it's for the finger, for instance, you wouldn't want to inject.
Yeah, that's a lot of quantity to put into a small area. Yes. So I know that a lot of different things can be treated, obviously, a lot of different ways. What's the ideal kind of situation that a patient would benefit from PRP as opposed to other things? Okay. So after doing some literature review, it shows, in 2018, there was a systematic review of all the trials and that have been recorded for, using PRP and comparing it with normal saline, comparing it with hyaluronic acid, which is a common treatment for musculoskeletal pain. And the consensus pretty much is, for the high level of evidence, it works very, very well for lateral epicondylitis or tennis elbow. Cool. And also knee osteoarthritis. Okay. But for what patient it would be most useful for, it would be someone that has gone through all the conservative management that's recommended. Right. For tennis elbow, for instance, going for physical therapy, taking non-steroidal anti-inflammatories, bracing, trying the corticosteroid injections, once or twice, or potentially even 3 times. And if this patient is not getting better, and they, the only option would be, prior to this regenerative medicine, would be surgery. Yeah. So now that we have the regenerative medicine, it's a great alternative for someone that doesn't want surgery or is not a surgical candidate. Yeah, I've looked at that paper as well. There's some, to me, there's a lot of ways to treat. You want to treat the individual, right? And so I always talk about kind of a stepwise approach with treatment with patients. We always try to do the conservative things first if we're able to, whether that's physical therapy or chiropractic care or medications. And then if you're in too much pain to tolerate that, or you've tried that and you're still in a lot of pain, that's when I'll talk about various injections. And I explain to them that cortisone or corticosteroid injections we've used around for forever basically, and a lot of times it helps temporarily to decrease inflammation. A lot of times it's the thing that actually really gets them better, but in some cases it just doesn't work, or we shouldn't be doing it. So for example, you mentioned tennis elbow, lateral epicondylitis. Studies are showing that a cortisone injection could be beneficial, but the more you do, the shorter time frame of relief you get per injection. So I'll often explain it. Yes, tennis elbow can be treated with the corticosteroid injection, but if we do it, you might get 6 months of relief. And then you come back and I do another one, maybe you're getting 3 months. And then I do another one and maybe you're getting a month. So it's not the best way to treat that, in my opinion. And then we look at the PRP injections, and I think that that's a great way to treat that. The studies, as you're saying, are really helpful. And I just kind of offer it as an alternative to the cortisone injection, because those types of injections can be helpful. And if it's beneficial for you and it's less invasive than surgery and less risky than surgery, then why not give it a try first? Yes, of course. And just back up a little bit, because I mentioned about Alan Mishra,
back in the 1990s. So he published a paper in, I believe it was 2005 or 2006, that was very impressive for lateral epicondylitis. And the patients had about over 90% relief after 2 years.
Wow.
Yeah. So that was like a very shocking point to sports medicine physicians saying, wait, we have a therapy that's this powerful.
Right.
We haven't been using it. So I think that was one of the things that also pushed the advancement of PRP.
The other big area that I think it's helpful for is Achilles tendonitis and tendinopathy, because studies are showing that we definitely shouldn't do cortisone injections into that area because of the risk of rupture.
Yes.
And you know, I've seen excellent success with PRP injections in the past. You know, just like anything, a lot of it depends on the patient, the extent of injury, but it's something else that I think is really helpful to use PRP for.
Yeah.
Have you had other things or other musculoskeletal issues that respond really well to it?
So I'm kind of in the infancy of performing the PRP, but I trained in San Antonio in my fellowship. And I saw phenomenal results with lateral and also medial epicondylitis, or golfer's elbow. I've seen it, moderate results with rotator cuff injuries, but knee arthritis does seem to be responsive to PRP.
Right.
And there also is different types of PRP, which I'll get into a little bit right now as well. There's leukocyte poor and leukocyte rich PRP. And since I talked about before, when we were spinning with a centrifuge, we throw away the red blood cells and the white blood cells. But in some instances, we actually keep the white blood cells and we inject that with the platelets and the plasma. And the studies do show that works more for the lateral epicondylitis injections, but is not so good for osteoarthritis.
Okay.
Yeah. And the leukocyte poor version of PRP has been studied with knee osteoarthritis and has been the one that showed significant improvement in symptoms and pain scores and in patient's function. Yeah,
I think, so why are the studies so variable in terms of their results? Why is that?
Okay. So the reason they're so variable is there's so many different manufacturers that make PRP kits. So the centrifuges are different, the spin times are different, the way that you extract the platelets are different, and also that number that I was stating before about how many platelets per microliter that you're injecting, there's so much variability to that as well.
Okay.
There are some more sophisticated kits that can extract the exact amount of platelets and the exact amount of leukocytes that you would like.
Are there set numbers of platelets that you should have for depending on... So one of the issues I think that there is with regenerative medicine and PRP in general is that there's a lot of variables. So how do you know what to inject and how much platelets you should have for somebody with advanced knee arthritis versus somebody with tennis elbow? Is there kind of a guideline? Yeah,
so I think that there hasn't been any strict guidelines to date, but I think if you have the kits for the leukocyte rich and leukocyte poor PRP, then I would choose leukocyte rich for tennis elbow or for tendinopathies, and I would use the leukocyte poor for knee osteoarthritis.
It's not such a cookie cutter type approach. I guess you got to really look at the patient, which is something we always try to do.
Yes, of course.
Look at the patient, look at the circumstances, and not say, okay, it's knee arthritis, so you have to do X, Y, and Z with a PRP injection versus tennis elbow. It's really up to how much you get and the cell count and what the underlying issue is. So I think that there's a lot of variability in terms of the factors that will go into it. What are some of the, so we've talked about some of the benefits of PRP injection. What are some of the risks involved with PRP injections?
So as we know right now, since the PRP is coming from your own body, so it's an autologous injection, that there are no real immune reactions that have been documented with PRP.
Okay.
The problem is there is a pro-inflammatory state that occurs after a PRP injection, which could last up to 1 to 2 weeks, potentially a little more or less than that as well.
Okay.
And in that case, you'd have increased swelling, pain at the area, but there's no real potential harmful side effects to it, at least at this point that we know of.
So what do you tell a patient who had an injection and maybe is concerned about the amount of pain that they're getting? Should they, should they take Advil or Aleve or one of the anti-inflammatories?
Okay. So that's a great question, Dr. Curtis.
That's why I asked it.
Yeah. So because of there are medicines, anti-inflammatories, including ibuprofen, Aleve, that affect your platelet count and your platelet quality.
Okay.
So it can affect the growth factors that are in those granules. So my rule of thumb is to stop any anti-inflammatories, including ibuprofen, naproxen, diclofenac, approximately 2 weeks before and also 2 weeks after the PRP injection.
Okay.
And then for the pain that's happening after the injection, Tylenol for pain and also ice. But if they can tolerate not using the ice, then I say to try to let the medicine do its thing. And then if they really need the ice, then they can use ice. But usually just Tylenol. And then there's also a problem with the antiplatelet agents, including Eliquis, Brilinta, because they also change the growth factors. And even warfarin, which you wouldn't think of as an antiplatelet. It's more of an anticoagulant. There is a study reporting that the growth factors are diminished in someone that was on warfarin and then got the PRP injection.
So do you advise patients who are on those medications to stop them before or afterwards?
So it honestly depends on what they're on the medicine for.
Okay.
So if for instance, if they're on anticoagulation for atrial fibrillation, and if they're off this medication, it can lead to catastrophic problems,
really
of stroke.
Bad things,
Then I always ask the patient. I always discuss the risks and the benefits of the procedure, and have them ask their cardiologist or their internal medicine physician, whoever's managing the medicine, to say, is it worth getting off this for 2 weeks?
Right. Are you still able to do the injection in general if they're on that medication?
Yes, you can still do the injection, but it's likely that the benefit won't be as powerful as if they were off of it.
Gotcha. Okay. So let's just kind of run through, I guess, a patient scenario and just talk about how you would approach and counsel them, just how you would manage it. So let's say, tennis season, the golf season is right around the corner with the weather being nice. Let's say you have a 30-year-old or a 20-year-old who's had epicondylitis, let's say lateral epicondylitis. You've tried, the conservative route, anti-inflammatories, physical therapy. What would you say to them? Okay.
So I'd want to know how long they've been doing the physical therapy, because sometimes it can take, a few months in order to improve the physical therapy. I'd make sure they're using the tennis elbow strap. I'm making sure they're doing all the things, because some patients, do the therapy, but I just want to make sure that they're doing the correct exercises. So we confirm that. But if it's failed and their pain is back, I tell them we can do the corticosteroid injection if they haven't had one already, and we discussed earlier, potentially repeat that in 6 months. But I always lie down the options for the patient. So I'll say, we could do the corticosteroid injection, but I would show them the paper from that study from Alan Mishra, and it's pretty compelling. So I would show them that paper, have them review it, and give them that as an option in case they don't want to do the corticosteroid injection.
I think it's certainly a valuable thing to at least offer, because like we've said, a lot of the alternatives to this would be, maybe go see an orthopedic surgeon to discuss surgical options, especially if you get an MRI and you've done diagnostic studies, and it shows that you have, just inflammation, maybe not a major tear that requires surgery. And it's certainly helpful to explore all options. So that's similar to how I would approach it. Now, when you do a PRP injection, how important is it to do it under guidance, image guidance?
So it's extremely important to administer our injections through image guidance. So in this office, anytime that we do an injection, it's either ultrasound guided or fluoroscopy guided to make sure that it's in the right spot.
Right.
So because in the olden days, the orthopedic orthopods would do landmark-based injections, and at the time ultrasound wasn't available.
Right.
But some studies have shown that it's much more efficient when you're doing it ultrasound guided or fluoroscopy driven.
Yeah.
To get it right in the right spot.
Yeah, I mean, it was kind of a setup question, but Grant and I talked about it last time on the podcast, how we were talking about with knee injections, the studies show that when you do it kind of landmark based, you're only getting it into the joint about 70% of the time. When you do it with ultrasound, it goes up to about 95%, 90 to 95%. So that's a big difference. And especially when we're trying to target a specific area with PRP, I can't understate how important it is to do everything under guidance.
Yes, and even getting back to that patient example that you mentioned, I would, since we have the ultrasound available, I always bring the ultrasound in. Yeah. I'll scan the area, look at where that the extensor tendon attaches, which is the area of it's the lateral epicondyle, and to see if there's any tearing or any calcifications there, and that can be a dynamic evaluation that we have in the office.
I think it's a great tool in our toolbox that could help out. So what's your kind of follow-up plan after you do an injection with PRP?
Okay, so typically I'll tell the patient the post-injection protocol about not doing anti-inflammatories, and also fish oils are another anti-inflammatory that they should be off of for about 2 weeks. Okay. And then the icing and the Tylenol. And then I would tell them for 2 weeks no physical therapy, or depending on where what the musculoskeletal problem is. If it's a weight-bearing joint, I just want them to take it easy and not really run or go out, do any stationary bike. I don't want them to really have too much activity at that joint or that tendon. But if it's the elbow, then yeah, they can run. But I would want them to just leave that area alone for about 2 weeks.
Sure. No excessive activity for a period of time.
Yeah, for about 2 weeks. And then I usually have them follow up in 1 month, just to kind of see where they're at. But a lot of the studies do show that the significant benefits from PRP injections are 3 to 6 months down the road. Okay. So so I'll do the 1 month follow up, see how they're doing, and then I'll have the 3 month follow up from when the PRP was administered. Okay.
And that's what brings up a great point. So 3 months go by and they're feeling great. How long does this last for? We always get that kind of question, right?
Yes. So a lot of the studies, especially for knee arthritis, are done with a series of 3. Okay. So they're PRP injections spaced out, and the studies are different. Some of them are a week apart, some of them are a month apart of 3 injections. But to answer your question about how long it lasts, we typically get that question about the corticosteroid injection and the lidocaine. So for this, your body is healing. So in order for your body to regenerate, it takes many, many months. Okay. And for instance, one of the growth factors that is released from the platelets is chondrocyte-derived growth factor. Okay. Which chondrocyte meaning cartilage, and there's a few others. There's epidermal-derived growth factor. So it takes time for your body to heal. So the effect is lasting over many, many months. Okay. And I always tell the patient, I at this point, depending on what the injury is or the musculoskeletal problem is, I'll reference the literature. And if it's only been done in a series of 1, then I'll just do the 1 injection, have them come back in the month, and then potentially we can repeat it in 3 months. Okay. But I want to know from the patient, was there a significant benefit? Sure. Or was there any benefit? If there was no benefit, then obviously we wouldn't repeat it.
I think, as much as we love to quote the literature, and you and I are very big on evidence-based medicine, as is everybody in this group, you have to look at the patient, and the literature is designed more for population-based, and it's really so important to look at the patient as the individual. So, as much as we like to lean on the literature, sometimes we have to think outside the box because the patient's case is a little bit different. So a lot of discussion with regenerative medicine is, and even with cortisone injections. So I get a lot of patients with knee osteoarthritis or any kind of arthritis where the cartilage that surrounds the joint starts kind of fraying or creating those pothole deformities. or tears. So, for example, let's say I have a 70-year-old man or woman. They get an MRI. It shows cartilage defects and tearing, and we do a PRP injection. Is it beneficial to get another MRI to see if it regenerated?
Yeah, so that's based on the current literature. I don't see many physicians doing that, but it's a tough question to do, because even with a lot of these injections, and we've only talked so far about PRP, and I'd like to talk about the other regenerative techniques, that we're not guaranteeing that you're going to grow new cartilage, you're going to grow new bone.
Okay.
Because repeating MRIs and repeating ultrasounds that, as far as I know, have not been shown to regenerate tissue, like radiographically.
Yeah.
But the benefits are the patient's symptoms and their function. They're more functional.
Right.
Usually.
Yeah, I've looked at some of the studies behind the knee arthritis, and one of the markers that they use is growth on MRI. And sometimes it does regrow, but that doesn't necessarily mean anything, because there are still patients who kind of have a little bit of regrowth who don't feel any different in that study. But then there are other people in that study who the MRI looks exactly the same, but they're feeling significantly better. So I think, to your point, that the injection doesn't necessarily mean that if we do another MRI, the tissue is going to grow back magically. I don't think we're there yet in terms of the advancement of regenerative medicine. But it's certainly something that the studies are showing can help with the pain and help with your symptoms. And I always tell patients that I treat people. I don't treat MRIs. If I cared about what the MRI looked like, then I would order it serially and make sure that it's improving. I don't do that. What I do is have you follow up so that I could examine you clinically and see how you're doing as the patient. So I think, a lot of patients will ask me when I do a PRP injection, okay, when are we doing the MRI to see if it worked?
Yeah.
I tell them, we don't need to do another MRI. I want to see you in the office so that I could re-examine you. You kind of just talked about that there are other injections besides PRP. So what other injections are available?
Okay. So there's, I'd say, 4 main categories of regenerative medicine. The first was prolotherapy, and that was the one that was started in the 1950s.
Okay.
So I misspoke before. The PRP was developed around the 1970s.
Okay.
But the prolotherapy it's actually been used even further. It's been used for 80 years, actually. So I think in the 1930s, but it was only deemed the name prolotherapy in 1950, and it's injecting an irritant into a tendon insertion, a loose ligament, a muscle strain of some irritating solution that causes platelets to get to the area and heal. Okay. So it's similar to PRP in a way.
What kind of irritating substance are you injecting?
So most commonly, it's dextrose is used, which is glucose, sugar water, yeah. And there's a percentage of the injection that is dextrose. So typically it's 12 to 25% of dextrose. And so that's the first category. And then in the 1970s, actually, PRP was developed by hematologists for treating low platelet counts or thrombocytopenia. Okay, makes sense. Yeah, exactly. And then it was experimented with heart surgery after that, and then it started being used in all fields, dermatology.
I know it's used a lot in cosmetics.
Yes.
Reduce some of the wrinkles that we get.
Yeah, exactly. And then another form of regenerative medicine, or a category of regenerative medicine, is stem cells. Okay. And the typical type of stem cell is a mesenchymal stem cell. I always quote my mentor from San Antonio, who'd always say, stem cell is a cell that doesn't know what it wants to be when it grows up.
Okay, I like that.
Yeah, so the mesenchymal stem cells are the ones that we're interested in because it has the ability to differentiate into bone, cartilage, fat, or muscle. Okay. And this can be extracted from different places. Okay. So mesenchymal stem cells can be extracted from fat cells or adipose cells from your bone marrow, which is a very painful procedure. Yeah. So in San Antonio, the physicians I was working with were also working with a plastic surgeon who was doing liposuction. Okay. And to extract the adipose cells, the stem cells, and injecting that into the knee for osteoarthritis for certain patients, which is a pretty interesting study. And the last category I would say is is others,
Okay.
and some of those include amniotic growth factors. So there's many companies that make a product from a placenta. So a placenta is donated after the woman gives birth, and then these placentas are pulverized, and the growth factors are extracted from the placenta, and that is injected into.
Is one more superior than the other in terms of different things?
Yeah, so that's a very difficult question to answer, and then so that we really don't know at this point.
Okay.
It seems like on a cost-effective factor, that PRP is probably the best for the money, because stem cells are more expensive.
Sure.
And they haven't been studied as much in the literature.
It's also a lot more invasive to harvest them.
Yes.
I think that's why, or I know that's why I lean more towards PRP or Prolo, because it's less invasive. And the first rule of medicine is do no harm, right?
Yes.
And so if we could do things that are effective in treating your symptoms and treating your pain, that are less risky and less, potentially harmful, then that's what we should try to do.
Yes.
And that's why I go with PRP. We're not, our practice at this point hasn't really reached the point where we're ready to do stem cells. Maybe in the future we could talk about it. But I know with working with Dr. Malanga up in North Jersey, who's written a number of books about this. He also talks a lot about stem cells and adipose cells as being superior sometimes depending on the situation. But I think PRP for our purposes really, really helps with the pain, with regenerating some issues, and is significantly less invasive or harmful in the way that we get those cells.
Yes, I totally agree. And there's also ethical problems with stem cells.
Yeah.
Because it's a cell from your own body, and there's ethical problems or questions with manipulating those cells and injecting them back.
Yeah, but it's not the same kind of stem cells, like embryonic stem cells from a fetus, right? It's not as controversial as you would hear as soon as you hear the word stem cells.
Yes.
You kind of get that picture of embryonic stem cells. These stem cells are your own body, right?
Yes.
And that's why it's helpful to heal your own body's kind of issues. The placental ones, I think because they're from a different source that's not native to your body, I think that needs to be looked at a little bit further in terms of some of the risks involved with it, which is another reason why I'm not jumping right onto that bandwagon at this point. But there is a lot of talk about it, going forward. But I think, at least for a lot of what we see in terms of the sports injuries and even the chronic injuries, I think PRP is really effective in a lot of cases. So if it's so effective, why aren't doctors using it as much as we should be, or should we be using it more, or should we not be using it more?
So currently, the FDA classifies PRP and these stem cell injections as experimental. So and it's because of what we talked about before. There's so many different kits. Yeah. There's so many different types of PRP with the high white cells, the leukocytes, or leukocyte poor, and there hasn't been high quality, large population data to confirm that it's really beneficial. So, and if that was the case, then the FDA would likely approve it to be covered by insurance companies. Yeah. And it's also, I think, difficult for them to approve it because it's not a medicine from a pharmaceutical company. It's a product of your own blood being injected back in. Sure. So I think that's some of the main setbacks and why we're not using PRP on everybody.
Yeah. Yeah, to me, that's the big issue, right? I'll often tell patients when I'm talking to them or counseling them about different treatment options, I often will say, look, if this was approved by insurance, I'd be using it first line on basically everybody because, one, it's effective in a lot of cases, and two, it's your own body's natural product, so there's significantly less drug reaction. There is, there's a little bit of pain, but that's actually a fairly good sign because it means that your body's going through a healing process. But otherwise, it's really well tolerated. It's no risk of anaphylaxis or anything because it's your own body. But as you said, I think the fact that it's not covered by insurance is the big issue. I think eventually we'll get there in terms of getting a standardization. But right now there's just so many variables, as you pointed out. A lot of it depends on the patient characteristics. So, how active are you? How old are you? What other medical issues you have? The second issue is the actual injury. Is this chronic or is this acute? Is this a tendon, a ligament, cartilage? Is this arthritis? Is it bone? Is this something that had previous surgery? Is this an area that's had repeated steroid injections in or no steroid injections? There's just a lot of different factors. And because of that, it's hard to really, as you said, make a protocol or for a large population issue. Hopefully we'll eventually get that one day, and then we could get this covered by insurances and could get it more mainstream to help patients out. In terms of, a lot of times we'll talk about PRP injections or regenerative medicine injections as an alternative to surgery. So I use, I'll talk to patients a lot with, let's say, really advanced knee arthritis who have a lot of medical issues that prohibits them from being a surgical candidate. I've had a number of patients with, advanced cardiac disease or pacemakers who are just suffering. I've given them a number of steroid injections. We've done the hyaluronic acid, the physical therapy. Now we're starting to talk about pain management with opioids, which is a whole nother topic of conversation. And I'll often talk about PRP as an alternative because you can't have the surgery. Let's try this to see if it helps. But if you have PRP in general, let's say somebody who is a surgical candidate and you have PRP, does that preclude you from having surgical intervention in the future?
I don't think so. I think that you can still try the PRP, and then if you don't respond to it, then you can think about doing the surgery. But back to that patient, I would probably do a series of 3 if it's someone with advanced or severe end-stage osteoarthritis, because as you were mentioning before, there's all these variables about activity, and the stage of arthritis is very, very important because it has been shown to be even a little bit better for stage 1 and 2 osteoarthritis as opposed to 3 and 4. Yeah. But if you're gonna offer it for someone with end stage, I would definitely say a trial of 3 spaced out probably a week apart or 2 weeks apart. Gotcha. Would probably be best.
So similar to like hyaluronic acid, the studies for that show that it's most beneficial for mild to moderate. But there are plenty of people who get significant benefit from it, even if they have advanced arthritis. It just may not be as long or may not be as effective, but they're still feeling better in the end. Yes. With surgery, the classic one is, or the one that they initially looked at was with rotator cuff issues. A lot of times they would do the rotator cuff surgery and actually inject PRP while they're doing the surgery to see if it speeds up healing. And I know a lot of orthopedic surgeons who do PRP injections in conjunction with surgery, usually more for tendon issues or ligament issues, soft tissue things, as opposed to putting a prosthesis in. I don't see a whole lot of PRP use with joint replacement. It's more for like the soft tissue things. Yes. And I think that it can be helpful in conjunction. I mean, a lot of times when we talk about patient care, a lot of it, how aggressive you want to be, depends on the patient, their level of activities, the extent of injury, what they want to get back to. For some patients, we do a full court press. We do PRP, surgery, heavy rehab, medications to get them back. Other times we kind of take things in a stepwise approach because, we have the time and we can try things one step at a time to see what works for you. I think that really hits a lot of the points with regenerative medicine and PRP. Where do you kind of see us utilizing this going forward in the future?
Okay. So back to that review article that I was seeing. So in overview for lateral epicondylitis or tennis elbow and for knee osteoarthritis, there's high level 1 evidence saying that PRP is beneficial, And then there's other injuries that there's moderate or inconclusive amounts. And some of those are rotator cuff, for instance, Achilles tendonitis, patella tendonitis. Those are just a few to name. But I think, as we learn more about this and as more articles are published, we're going to have a more concrete understanding of why it's not working for those those conditions as well as lateral epicondylitis. And I think we need to specifically know how many platelet, when we were talking before about what is the actual platelet number that's being injected in, because if it's a higher platelet number, it has more growth factors.
Sure.
But more isn't always better.
Right. Does that necessarily correlate?
Yeah.
Not all the time.
Yeah. So I think over time we'll find what that perfect balance is of how much platelets, how much white blood cells for each diagnosis.
Yeah. Yeah, to me, I think that this field of regenerative medicine, it's very exciting. It offers a lot of promise. And for some patients, it's a great way to treat their chronic or even acute pain. It's another tool in our tool belt that we can use to help people. But I agree with you. I think that there's a lot of kinks that need to be worked out to make this more of a population-based treatment. And hopefully in the not too long future, in the near future, that we'll get more studies and we'll have better technology, better techniques, and this will become more mainstream where we can use this more as a first-line agent to treat pain.
Yes, I definitely agree.
Cool. I think that basically sums everything up. Do you have any last-minute points or anything else?
I just want to, because we were talking before about the hyaluronic acid.
Yeah.
And with someone with a knee osteoarthritis, if they haven't tried the hyaluronic acid, I would recommend doing that before the platelet-rich plasma, just because at this point it's covered by insurance.
Yeah.
So and that is a lot of times the problem with these injections. So I would say to go with the hyaluronic acid, and if that doesn't respond, then that's when we go to PRP.
Yeah, PRP
or regenerative in general.
Yeah, I think that's true, and that's how I approach patients too. I say, I'm not pushing hyaluronic acid over PRP because it's necessarily better. I'm doing it because I know insurance will cover it, and there's a lot of mixed feelings about that. That being said, we'll try it first, and if you're feeling great, wonderful. Then we don't have to try regenerative medicine or PRP. If you're not, then we could step up and kind of think outside the box and try one of these PRP injections or a series of them, and hopefully that gets you better. I think that's a great way to kind of approach that.
Yeah, I agree.
Cool. All right. I think that's it.
All right. Well, thanks for having me.
All right.